Alrighty folks, I'm coming to you again, once again, from my hotel room, this time not in Vietnam, but I moved on. Since then, I left Vietnam, went down to Taipei in Taiwan to do a couple of days of presentations over at the APAC meeting, and attended the APAC meeting, which was really a great meeting. It was a lot of people there, and it's a great opportunity for education as well as getting together and seeing old friends and people in the profession. And that session's now over, and I'm on my way back, and I had a stopover here in Thailand, and possibly was going to do a trip down to China too. And so I figured while I'm here, since my last presentation that I had for you from my hotel room in Ho Chi Minh City had a lot of comments and questions that were either posted or were sent to me in private about the single visit endo, I figured I'll spend a little bit of time here to answer those questions that I thought were of importance to all of you. Somebody asked, so what you're saying that if I can dry the canal, then I can fill it in one visit, right? Now, again, I want to be clear. Drying the canal is not the main objective. The main objective is achieving adequate cleaning, shaping, and disinfection before you can fill the root canal. So that's the main objective. If you've achieved all of that in a single visit, then you do it in one visit, but you would take otherwise as much and as long as necessary if you haven't achieved the adequate cleaning and shaping, which then begs the question of what is adequate cleaning and shaping? Now, of course, while this is a more subjective criteria, you have to understand that part of the reason why people do multiple visits is because they feel like those areas of the canal they can't reach, they would like to chemically reach that with their calcium hydroxide. Therefore, if you are more interested in achieving single visit endo, then achieving touching of the canal wall, especially in the apical 3 millimeter, and enlarging that to a little bit of a larger size is much more important. So this minimally invasive movement comes at the price of really having to do things in multiple visits by allowing chemistry of the chemicals such as calcium hydroxide to stay in the canal in order to disinfect it. If you want to do cases in a single visit, you then rely more on physical cleaning of the canal wall with a nitrile file blade by going to a larger diameter. I use like a 30 at a minimum. However, it depends again for what kind of canal you're dealing with, how much curvature you have. So gauging the canal and then increasing it to a couple of sizes, 2 or 3 sizes beyond that apical gauge that you've achieved becomes a little bit more of an important factor. So you need to kind of understand that while cleaning and shaping in endodontics is something that is a little bit more nebulous and more subjective, at least based on the histological evidence of the diameter of the root canals towards the end of the canal, then knowing that touching most of the walls by going to a larger apical diameter and having a more biological apical preparation would be more ideal than going with this minimal shaping. If you are going to go with minimal shaping, then you are going to rely more on the chemistry of the chemicals and the disinfectants you need, and in those cases you may end up having to do cases in 2 visits for that reason alone. And the other question that came up that I thought would be of some importance for everyone to know is for those people who ask, well, what if I want to see what happens with a case? Let's say I have a tooth that has a crack, or there is perforation, or there is internal external resorption, or any of those other things that I don't know if this tooth is salvageable. How would I manage those cases in a single visit? And the answer is that with the modern obturation techniques, such as hydraulic condensation and factor techniques that I discussed at this APAC meeting, which hopefully I will make a video about that as well separately, The obturation time from the moment at which you know you've done adequate cleaning and shaping is literally 5 minutes or less. So most people would have another 5 minutes to spend at the end of the cleaning and shaping rather than just place calcium hydroxide and then have the patient come back in again for another full half an hour to an hour visit. So that saves you a lot of time by completing the case. Now, when you see the patient for the second visit, it would then just be an evaluation. And if you decide that the tooth is salvageable, then the patient moves on. But the best way to manage these types of cases is, instead of bringing the patient back for a fill appointment, bring the patient back in for an evaluation appointment after you've already finalized the fill in the first visit, and then evaluate and see if this tooth is in fact salvageable. If the tooth is not salvageable for whatever reason, symptoms persist, area hasn't healed, so on and so forth, then what you are going to do is you can reimburse the patient always for the difference from what they would have paid in a single first visit for an exploratory compared to now. And what I have done this now for a number of years, and to be honest with you, it's very efficient and much better for the patient. It's completely a win-win scenario, because what ends up happening is that the vast majority of cases in these situations do well, and you end up just evaluating and checking the patient and then let them continue on this endo-restorative chain. And that is actually why you usually want to see the patient for the second step, is to just kind of make sure that you have okayed the tooth for the next steps of further investment into the tooth with a core buildup and a crown. When I do my root canals in a single visit, I immediately place some blue BC liner bonded into the access preparation, and now I have adequate time for that patient to float and wait until I am able to assess the healing of the tooth. For example, if it's a crack that is questionable, I now have the ability to have the patient come back in about a month or 6 weeks later or 8 weeks later sometimes, and then make sure the tooth is completely asymptomatic before they proceed with the placement of the restoration, because that's one further investment into the tooth which you need to kind of validate. So that's very simple to manage. You just have to be able to write a check for the reimbursement of the case if the tooth doesn't work. It's much better this way than to bring so many of these people back for the second visit when just to see if the tooth has worked, whereas it's much easier to just reimburse them. Or you can also, if they decided to have the tooth extracted at that point, you can invest that money into the extraction for them. You can do the extraction for them for free at that point, or rather just credit that money towards the extraction. Or if the patient goes back and if they want to have the person who's going to do the implant do the extraction, I usually require them to bring the tooth back for the reimbursement, the extracted tooth back. And the reason I do that is not so much so that they don't end up getting reimbursed and keep the tooth at the same time, although some people are capable of doing that. The main reason is because I get such a wealth of information from that extracted tooth that I had completed the root canal on recently and now is removed. By doing sectioning and evaluating the tooth, you can learn so much about your technique and which areas have to be improved, whether you actually did clean as well as possible isthmuses and those little areas, and that can help you understand better the quality of your irrigation. So this has always been very helpful for me in these scenarios. And by doing this reimbursement, you're able to have a win-win situation in which you win by not having to waste an extra session with having the patient come back in for treatment time. The second visit is just an evaluation or follow-up. You also learn a lot about the outcome of your cases and how they do 6 weeks later or so. And then also the patient wins in the sense that they don't have to have a second unnecessary visit that is treatment visit, and that you also get a chance to evaluate the tooth after you've done the endo prior to them getting the next restoration, as well as having the benefit of being reimbursed and not having to take unnecessary risk if the tooth was not going to work either way. So I think this is probably the best approach to this types of cases. Of course, the question that come up is about perforations. But of course, perforations, you need to repair the perforation right away. So that's really a critical component of that. Let's see, the last one is if a patient has an abscess and is in a lot of pain, would I do that in a single visit? And the answer to that is that while there are, in fact, studies have been done in UCIO that shows that it can be done in a single visit and that doesn't have a deleterious effect on the success rate of the case, these types of situations, it would probably be more prudent because you would be able to then, if there is a big flare-up, allow yourself to get back in and do some more cleaning. It's just probably better and safer in these types of cases to be more prudent. And then last but not least, keep in mind that the success of your case is ultimately a function of not just your treatment planning, which is going to be the treatment planning and case selection for the types of cases that you're going to be doing in a single visit based on their anatomy, based on the given requirements of that patient, but also, more importantly, about your patient communications and your ability to discuss with the patient what you're doing and being transparent about the risk involved. And then be credible enough so that when these types of cases don't fare well, that you are reimbursing the patient readily. And I sometimes, even in cases in which the patient is having a tooth that I'm beginning to do the root canal on, but I'm really not sure about the restorability of this tooth, I will complete the endo since I already have the appointment for the completion of the tooth in these types of cases. Instead of stopping mid-treatment and sending the patient to the restorative dentist to make the decision about restorability, I will complete the case, and then in the final report, I would write to the general dentist that if they decide to have the tooth removed due to a lack of restorability, that this is going to get reimbursed short of an unrestorable tooth fee, which is essentially an exploratory procedure. So this is the way we have to think. We have to constantly think about having win-win-win type of outcomes. As endodontists, the best situation is one in which we maximize the patient's ability to keep their teeth and then minimize the risk by doing these types of maneuvers, and then keeping our restorative dentists informed by communicating with them as well about the fact that we have completed the case, but they have the freedom to make the best decision for the patient based on what's good for them. All right, so I don't want to make this too long. This was just a quick one to kind of discuss some of the questions that have come up that I thought were relevant to everyone on this concept and idea of doing your non-surgical root canal therapy cases in a single visit. The most important thing is achieving the objectives of doing the full cleaning and shaping in a single visit in the cases in which you're questioning whether the tooth is going to be restorable and how it's going to fare. Instead of making a second visit, make the second visit your evaluation visit, but be ready to have the patient be reimbursed if the tooth didn't work out. You'd be surprised to find out how successful endo is, and in many of those cases where you thought you're going to see the patient for the second visit to see how it's going to fare, that the tooth is actually worked out. And in the very few in which it hasn't worked out, just be ready to pull out that paycheck and pay the patient back the amount that they've paid. And if you're a practice owner, that would be easy. But if you are an associate, that's something that you can clearly discuss with your practice manager or the practice owner in terms of the strategy that you use here to complete cases and reimburse if needed by doing that. And BC liner placement in the access preparation in these types of cases and bonding it instead of placing cotton on cavit is a critical and a key point, because you're able to keep these patients maintained for a fairly long period of time. The longest one I've had during the COVID with the BC liner in the tooth was 3 years, where the patient went away and came back for another root canal, and the patient had not gone back to general dentist to restore the tooth. Luckily, since I had that blue BC liner in the access instead of cotton on cavit, that tooth was still sealed, whereas in no other situation that would have been sealed and would have had to be redone. All right, guys, I'm gonna keep it short. Sorry, have a good one. I'll see you in the next video.